is going to be making sure that we administer reversals. And so we'll keep going here. So number one, minimizing our delay to CPR. So we talked about early recognition of CPA is very, very important. And 5 seconds or less being our cutoff if you can take the minimal amount of time possible. And in multiple studies in humans and in veterinary medicine, assessing patients, do we think that assessing patients for a femoral pulse is a sensitive or insensitive test? All right, that just sounded garbled. What did you say? Good or bad test?
Bad.
Bad test. Terrible test. So if you take 1 or 2 seconds to feel a femoral, if you feel one, great. If you don't, you should start CPR. But spending any more time trying to assess a femoral pulse is not going to be a really useful endeavor.
So essentially like when in doubt, start CPR.
Absolutely. Whenever in doubt, start CPR. So basic life support, first step, starting chest compressions. And can anybody tell me what the goal of chest compressions is? Huh?
I'm just not really. I'm trying to think.
Why do we do chest compressions? Anyone?
For the blood flow.
Yeah, blood flow. So we're trying to mimic general blood flow like the heart would do. Now, good chest compressions, high quality chest compressions, what percentage of normal cardiac output do you think we're getting?
40.
40 would be fantastic. 30 to 40 is a pretty average number during high quality chest compressions. And so chest compressions are going to be really important because even the best chest compressions are going to do a much poorer job than a heart that was beating even okay-ish beforehand. So chest compressions, we have a number of ways that we can do them, and the ways that we do them are oftentimes going to depend on patient size and conformation. There's no difference in quality of compressions between left and right lateral recumbency. So there is no need if a patient is in right lateral to flip them to left or vice versa. It's a waste of time. We want to be doing compressions. The optimal rate for chest compressions is usually going to be somewhere between 100 and 120 compressions per minute. There are some studies looking at higher frequency of chest compressions, between 160 and 200 beats per minute. And interestingly, some early studies suggested that potentially having a higher heart rate, like 160 or 180, might have been beneficial. And then some more recent studies came out and said that it led to increased fatigue without a significant increase in the quality of chest compressions or cardiac output in those patients. And so I think, especially for a hospital that has generally a smaller staff, and thinking about patients that might be here early in the morning, in the afternoon, late at night, when we don't have 8 people wanting to rotate through chest compressions, trying to preserve staff that can do good quality chest compressions at 100 to 120 compressions a minute is better than trying to do them as fast as possible. So there are a number of songs that you can use to get the appropriate beat for chest compressions. If you're very positive, you might like Staying Alive. If you're a negative person, you might like Another One Bites the Dust. But if you go on YouTube, there's like a bunch of great ones, so you can always go home and look at those. The ideal compression depth during chest compressions is somewhere between 1/3 and 1/2 of the width of the chest. So pushing it down so the chest compresses about a half is generally the goal. And if you had to say which portion of the chest compressions, pushing down or releasing to allow recoil, which portion would you say is more important to achieving cardiac output and blood flow? Pushing down? All right, here's a pen for pushing down. Anyone else? Someone thinks both? Who thinks both?
Dr. Patel.
Wynn thinks both. Dr. Patel thinks both. All right, anybody else think it's just letting the chest come back up? There's a free pen in it.
Yeah.
Ah, there she is.
I got one.
You've already got one, great. All right, so the answer is that both are important, and depending on the size of your patient and the theory that you're following for your chest compressions, one may be really crucial, more than the other potentially, but they are both equally important in many patients. And so we're going to look at 2 different theories. So if you look at the dog on the top picture, nope, that's super blown out and no one can see that. All right, so the dog on the top picture, do I have a cursor? All right, so if you can see my cursor a little bit, so the dog in the top picture someone's doing chest compressions here, essentially over the widest portion of the chest, and the heart is probably here. Is that like you guys can vaguely see that?
Mm-hmm.
Okay, great. So then the dog in the second picture, the person is doing chest compressions right here directly over the heart. And then the dog in the third picture, this is a very sad English bulldog that is laying on its back and getting chest compressions like a human, so straight over the sternum. And so there are two main different theories regarding chest compressions in veterinary medicine. One theory is the cardiac pump theory, and the second theory is, and they're both labeled 1, that's great work, the thoracic pump theory. So the cardiac pump theory is really simple. You try to push on the heart and push blood out of it. So the cardiac pump theory is our second picture that we can't see, where we're pushing directly over the heart. And if you had to guess atria or ventricles, which chamber you'd want to be pushing on, if you could pick? Absolutely, ventricles. So the ventricles are the chambers that are pushing blood to the lungs and out to the body. So you want to try to be pushing over more of the apex of the heart where the ventricles are. And patients that this is ideal for are smaller patients. So different papers use different weight cutoffs, but somewhere around the 10 to 15 kilogram mark. Most of those patients have a compliant enough chest that you can do chest compressions directly over the heart. Other patients that are really keel-chested or narrow-chested, like greyhounds, where you feel like you can get good compression directly over the heart, absolutely we can do that. And then if we think about other larger breed dogs that may have a slightly wider chest and less sort of compressible than something like a greyhound, maybe like a Labrador or a golden retriever, the idea is similar but somewhat the opposite. And so rather than trying to directly compress over the heart, our goal is to try to compress over the widest part of the chest and manipulate intrathoracic pressures. And so what we do is push over. If a patient's laying on their side, if you look at where the chest sort of comes to its highest point, we want to push there. And the goal is to say we're going to push on the chest, we're going to create an increase in intrathoracic pressure because we're pushing down, and that increase in intrathoracic pressure is going to push blood out of the chest cavity and push it out to the body. And then as we release, really importantly for the thoracic pump theory, we're going to get blood that gets sucked from the body back into the heart as we create negative pressure, releasing the chest. And so that's the idea of both of those being really, really important, and potentially making sure you fully release and let the chest recoil is going to be important in that thoracic pump theory. And less of a theory, but more of a conformational difference is our bottom picture with our sad English bulldog. Those patients that have barrel chests and look a little bit more like a human conformation may benefit from chest compressions on their back, so in dorsal recumbency, and doing chest compressions just like you would in a human trying to push directly over the heart. I would say that probably in the English bulldogs that I have done CPR on, somewhere around 2/3 of them to maybe 3/4 are better that way, and I think probably somewhere around 1/3 or 1/4, somewhere in there, are still better done in lateral recumbency using the thoracic pump theory. And so it's sort of to your judgment, and we'll talk about ways to monitor quality of CPR in a little bit. But if you feel like, hey, I'm doing really good CPR, we caught this early, and the test that I'm looking at says our CPR is not great, that might be something that motivates you to switch from dorsal recumbency into lateral in a patient like that. So this is just a summary: cardiac pump theory, medium to large breed keel-chested dogs, cats and small dogs, and thoracic pump theory, medium to large breed round-chested dogs or obese cats and small dogs. And so it can be really variable. There is no specific cutoff for anyone to say what's best, and oftentimes making some manipulations during the course of CPR and monitoring some specific values, which we will talk about, is going to be a better indicator and a better way to assess your CPR than just saying the textbook said so. Also, if anybody has questions at any point, just interrupt me and we can talk about anything. All right, so flat-chested dogs, cardiac pump theory and dorsal recumbency, French bulldogs, English bulldogs, I would say most of the time, but not always. Is that true? So the next step in our basic life support is going to be ventilation, and the ideal way to do this is to intubate while we are performing chest compressions. So to not stop chest compressions ever, and to be able to do our chest compressions in lateral recumbency and intubate the patient when they're lateral, and then start providing ventilation. So the ideal is somewhere between 8 to 10 breaths a minute. I teach most people just to do 10 breaths per minute because that's a breath every 6 seconds, and it's a lot easier to do the math. And an inspiratory time of 1 second is usually pretty simple. Most people can count like 1 Mississippi while they're squeezing down on an ambu bag. I would say another important thing to know is that you don't need an ambu bag. So if you're somewhere where you are closer to having an anesthesia machine, you can use a reservoir bag and give breaths off that just like you would for a regular apneic patient under anesthesia. So don't stress, especially like I've seen people who have patients under anesthesia on a circuit and like have a patient code and pull them off and grab an ambu bag, like make more work for themselves. There's no need to do that. There's no specific benefit of an ambu bag if you already have an anesthesia machine close by, which I think is very important to know for patients that are in surgery or patients that code like right here and we happen to have the anesthesia machine like in treatment right in front of them. Like you can just plug that in and hook it up. If the ambu bag is easier for whatever reason, great, use that. It's certainly not worse. That leads me to my next question. What percentage of oxygen would you like to deliver for a patient that is getting CPR? Do you want them on room air? Do you want them on a mixture of room air and 100% O2, or do you want them on 100% O2? Anyone? 50-50? 100%. So fine to just turn the O's on. None of our anesthesia machines at this hospital or most veterinary hospitals are going to be able to mix room air with 100% oxygen. The reason that I bring it up is that if you're using an ambu bag, you should always remember to plug in oxygen as well, so you're not just ventilating them with room air. One important thing is to be aware of peak pressures. So most of the ambu bags have kind of a cracking pressure where you'll hear that noise if you start to go over 20 centimeters of water in a breath. So the ambu bags have a safety that way. When you're doing breaths off of an anesthesia machine, be cognizant of the manometer and make sure you're not going over 20. And certainly there are times when you'll give a breath and someone goes to do a compression at the same time and it'll like shoot up higher than that. That's inevitable, but don't stress about it too much. Just try to be aware of it in general. So if for whatever reason you are unable to intubate, which we should not be here, but if you were doing CPR in an extra hospital setting, mouth to snout ventilation is an alternative, but it is a much poorer alternative, so we should never resort to that here. In humans, they frequently use tight-fitting face masks, and there are a number of human studies that suggest that tight-fitting face masks are equally as good in settings like this to perform CPR. Unfortunately, in dogs, due to their different sizes and conformations, it's really difficult to get a tight-fitting face mask, so that's not an option we have. But just if anybody is like reading at home about like why do we have to intubate when they don't do this in humans, it's because humans are generally all human-shaped and dogs are wild. So our next step, moving into advanced life support, is going to be monitoring. And our two forms of monitoring are ECG and capnography. And these are both really, really important. Some would argue that one of them is more important than the other for the vast majority of veterinary patients, and that's probably not true in humans. But so let's say ECG, what are we looking for on an ECG? Say that again?
V-fib or not.
Great, V-fib or not. Yeah, so V-fib or pulseless VTach, and why would you care about that?
There's only one that you would use.
Great. And so what's the most common reason for CPR in dogs? What's the most common arrest rhythm? Asystole. Who said that? Nailed it. Another pen. Everyone gets pen. All right, so asystole in veterinary medicine is the most common arrest rhythm, and we'll go over a little bit what the different arrest rhythms would be. Asystole, or something called PEA, pulseless electrical activity, which means that the EKG reads like you have a pulse, so you can see a normal PQRST, but the heart's not actually beating. And then in humans, more commonly, we see things like ventricular fibrillation, which we're looking at on the rhythm strip below on the left, or pulseless VTach, which for our purposes, since we're not doing a cardio talk, we're going to say are essentially the same. So our examples on the left, the top one we said is V-fib, and the lower one we would say is asystole with some like baseline artifact, probably from movement of the patient or movement on the table. And the differences between those two things are really important because for asystole or PEA, we are going to do chest compressions and drugs. And for V-fib or pulseless VTach, we are going to defibrillate. So that's one reason that we're going to want to be looking at an EKG. In humans, they have a much higher incidence of V-fib, so they much more frequently defibrillate and then follow with chest compressions. So, has everyone seen the Emma that we have in the crash cart? Great. So the Emma is a capnograph. It is what's called a mainstream capnograph. We have other mainstream and side stream capnographs in the hospital. That's probably beyond the scope of this conversation to talk about the different technologies. But those look at what's called end-tidal CO2, and end-tidal CO2 is a really good marker for knowing how good our chest compressions are. So a patient who is alive, does anybody know a normal end-tidal CO2? 35 to 45, yep. So somewhere in there. So a patient who's alive has an end-tidal CO2 of 35 to 45. A patient who is dead and not getting chest compressions or ventilation would have an end-tidal CO2 of 0. Great. So when we see that it is lower, that is worse. When we see that it is higher, that is generally better, within the context of CPR, not within the context of general medicine. So don't go say, like, my patient's end tidal's 100, he's doing great. But this is a really good way for us to assess the quality of our CPR in general. And if you're doing everything right and your end tidal's still 3, sometimes your patient was just very, very dead, which can happen probably more frequently with out-of-hospital cardiac arrests. But if we said, for example, we had a patient who was an obese cat and we were doing a cardiac pump theory and the end tidal was 9, and someone slid back farther on the chest to do a thoracic pump theory and the end tidal CO2 jumped to 16, the conclusion that we could draw might be that that patient is benefiting from chest compressions according to a thoracic pump theory better, and the quality of our CPR is higher. And there's actually a single veterinary study looking at end tidal CO2 during CPR, and that study suggests that an end tidal of 18 or greater is associated with a significant increase in ROSC. So, in general, higher is better, but if we can get to 18 or greater, we tend to have a higher incidence of getting patients back, getting return of spontaneous circulation. So every CPR should have EKG and a capnograph. Do we need to have things like a blood pressure put on and a pulse ox put on? Probably not in any of those cases. If we achieve ROSC and get a patient back, great. Throw on all the rest of the monitoring. But in the context of our CPR, that's going to be our most important 2 sources of monitoring. So this is the paper that I mentioned from JVEC 2018. And an end tidal of 18 or greater was associated with ROSC. So that's a really important number for us. But I think the idea of just looking for a higher end tidal, meaning higher likelihood of ROSC or better CPR. And I think the other thing to mention is that if we ever see an end tidal jump, that might be an indication that you would see the doctors stop and reassess even midway through a round of CPR. So for example, if my end tidal goes from 10 or 11, 12, 9, 11, and then it goes to 28 very suddenly, I might stop chest compressions and look at my patient and say, okay, maybe we're back, because it's a frequent finding that if that end tidal jumps, you might have gotten your patient back. So next step, obtaining vascular access. So IV catheters, cut downs, IO catheters. I'd say far and away the most common form of access that we use in veterinary medicine, and at this hospital specifically, would be IV access. So sort of best case scenario, for a number of reasons, your patient already has an IV catheter and it's like under anesthesia. So you can go ahead and give them drugs right away. You don't have to wait to obtain access. I think that when we start to talk about, and we'll define a couple of roles in CPR, I think that obtaining vascular access as soon as you have gotten chest compression started and ventilation going and put monitoring equipment on, then getting vascular access is next. And I think that if we have a surplus of helpers for a CPR event, having multiple people try to obtain vascular access at the same time is a really great option. So if you have 2 people doing CPR because it's the middle of the night, or nobody knows because you're in the OR and you happen to just be there alone and no one can hear you screaming, I think that, we go through our steps: chest compressions first, ventilation second, getting monitoring on third, and then vascular access. If we have 8 people standing around a stat patient, it is very reasonable to try to have 2 people getting vascular access at the same time. And I think in general, this is not the time to be conservative. So if we're not very quickly getting a peripheral catheter in, I would jump to a jugular cut down pretty quickly. And if anybody has questions about how to do that, we can certainly go over that in more detail. And then another option for small patients, especially neonatal patients that have softer bones, would be intraosseous catheters. And discussing that's probably outside the scope of this conversation. So once we've gotten vascular access, we already talked about one type of drugs, so reversal agents. So we said reversal for opiates is going to be naloxone, the reversal for benzodiazepines is going to be flumazenil, and then the reversal for our alpha-2 agonist is going to be atopamazole. And then trying to give drugs like vasopressors, parasympatholytics, antiarrhythmics, and possibly IV fluids. So can anybody tell me what the most common vasopressor we might give during CPR would be? Huh? Who said that?
David.
Yeah, epinephrine is the single most common vasopressor. And can anybody tell me a parasympatholytic that we might give? Great. Who hasn't gotten a pen? I'll get you this little ducky. And can anybody name any antiarrhythmics that we might give during CPR? For a watermelon. Great, great. Yeah, so there are a number of other drugs. And then can anybody tell me, this one's probably harder, one indication to give IV fluids during CPR? Huh? Anyone? Potentially. Anyone else? Low blood pressure? Yeah. Absolutely not. They're dead. They don't have blood pressure.
No, it's David.
What'd you say?
I'm going to do it, David.
Or shock?
So I would say probably the best answer to this question is if you died from hypovolemic shock, then probably fluids are going to help you. The caveat to that is if your hypovolemic shock was hemorrhagic shock, so if you died from blood loss, it's probably better to give you blood than it is to give you Normasol because you didn't lose Normasol. But if you like pooped yourself to death, maybe replacing with something like Normasol might be better. And in general, does anybody think that IV fluids should be given in most CPRs or rarely in CPR, if you had to guess? Absolutely, rarely. So this is an emergency drugs and doses chart. It is also blown out, but luckily we have a big version of this on the wall next to the crash cart, and we also have smaller versions of this around the hospital. And this lists doses for epinephrine, both low and high dose. Unless it is specifically specified, epinephrine is always given at the low dose. So if you're ever not sure, we are always giving low dose epi, unless somebody tells you absolutely this is intended to be high dose. And then it shows doses for vasopressin, atropine, some antiarrhythmics, amiodarone and lidocaine, and then the reversal drugs we talked about, naloxone, flumazenil, and atopamazole. And then it has guidelines for defibrillation, for both external and internal defibrillation. I would say from the technician's standpoint, if you're going to try to remember some of this, it is okay for you to not remember the defibrillation stuff because you probably won't be picking that dose in most circumstances, particularly the internal, like you probably shouldn't be having to pick that ever. But importantly, there are different doses listed for biphasic and monophasic defibrillators. So if you're ever looking at the chart because the doctor can't remember and is asking you, all of the defibrillators that we have are biphasic. All modern defibrillators are biphasic. So if you're ever looking for answers there or trying to look that up, always look at the biphasic and not the monophasic. So in terms of CPR drugs, the order that we want to give all of our emergency drugs, if we have any drugs on board that can be reversed, we always want to reverse those first. So this is just a list of drugs that we have talked about multiple times now. Questions on this at all? Fantastic. So we said one round of CPR, basic life support, is 2 minutes. And every 2 minutes, so between rounds of CPR, we're going to reassess our EKG to see if we have persistent asystole, probably the most common, or if we have gone from asystole into something like VFib, which we would need to treat with defibrillation, or if we've gone back into something like a sinus rhythm and achieved ROSC. And so what we would be looking for would be a sinus rhythm on the EKG with something like an auscultable heartbeat and a palpable femoral pulse. So if you have all of those things, you have ROSC. If you have what looks like a sinus rhythm, but you cannot hear a heartbeat or feel a pulse, does anybody know what you would have? PEA, absolutely. You can't have any You're penned up over there. So if we're in VFib or pulseless VTAC, we're going to defibrillate. If we're in PEA, we're going to continue compressions and begin to give drugs. And so what that means is when we start CPR, we should be doing 2 minutes of chest compressions and breathing before we give drugs. If we have a patient who has been had an out-of-hospital cardiac arrest, I think that many people will give drugs as soon as we can get them in. And I think oftentimes it is okay to do that because by the time we've gotten a catheter in and we have obtained access, it's usually somewhere around that mark. And so it's probably more important to give drugs as soon as possible. If we have a patient who has an in-hospital cardiac arrest, particularly a patient like a patient who is undergoing anesthesia or in surgery, I would say far and away starting chest compressions and giving reversal drugs and seeing what happens and waiting that 2 minutes is going to be better. And the reason for that is in human and veterinary medicine, the cumulative epinephrine dose is associated with long-term mortality. And there are some interesting studies in humans that show really clearly that the more epinephrine you give, the more patients you get back. So you get more patients back with high-dose CPR, but the higher that total epinephrine dose, meaning all of the rounds of drugs they've gotten during their CPR, the higher the mortality rate overall. So what that means is you will get patients back and they will die again and not be discharged from the hospital. So in general, we want to try to give the least amount of epinephrine that we need to. So if a patient has a complication under anesthesia that we suspect is an anesthetic complication leading to arrest, turning off their inhalant anesthetic, their ISO or their SIVO, reversing their injectable reversible drugs, and doing 2 minutes of CPR before giving any drugs is probably our best bet. But for those patients that get hit by a car and they come in 30 minutes later, generally getting a catheter in and giving them drugs as soon as you can is fine. So this is our advanced life support. So if we have asystole or PEA, this says low dose epinephrine every other BLS cycle. So every other BLS cycle means every how many minutes?
6 minutes.
Great, 4 minutes. So one BLS cycle is 2 minutes. So we give drugs every how many minutes? Every other BLS cycle, 4 minutes. Great. So we don't give drugs every 2 minutes, we give drugs every 4 minutes. And we generally give epinephrine, and then we say consider atropine. Atropine hasn't really been proven to be beneficial in terms of achieving ROSC or keeping patients alive, but it also hasn't shown to be harmful. So most people tend to just give it, at least for the first 3 or so rounds. And then there are some questionable things. So if we've done CPR for longer than 10 minutes, do we have a really severe metabolic acidosis from poor perfusion? Do we administer something like bicarbonate? There is no strong evidence to suggest that it's helpful or harmful. So some people will give it for prolonged CPR. Some people have a cutoff of 10 minutes. Some people have a cutoff of 15 minutes. So I would defer to whichever person is making that decision. And then there's a question of, do we do high dose epi? And again, the more epi the patients get, the higher their mortality, the lower their discharge rate from the hospital is going to be. So that'll be up to the person who's making drug decisions during CPR. So sympathomimetics, so breaking down that word sympatho, like sympathetic nervous system, and mimetic, like mimicking the sympathetic nervous system. So they have a positive effect on the sympathetic nervous system, which is your fight or flight. And so they have a number of effects. So they have beta-1 effects, and beta-1 receptors, importantly for us, are located on the myocardium. So they help the heart to beat faster and to beat harder, and probably outside the scope of this conversation, but they also help the heart to relax faster. So it doesn't just squeeze faster, but it also relaxes faster to fill up with blood. And they also increase the speed of conduction through the AV node, which if anybody is a cardio nerd, you'll know that that's basically where the heart normally slows down conduction so that we can have contraction of the atrium before we get contraction of the ventricle, so that we can have really good timing between those chambers. They also have beta-2 effects, so we have increased ventilation and bronchodilation. And then probably one of the main reasons that we want to use these drugs is the alpha-1 effects. So alpha-1 receptors are located in the vasculature, and alpha-1 agonism leads to vasoconstriction and increased blood pressure and vascular resistance. And the reason this is important is that the goal of CPR is to get blood. If you had to pick one area that you'd like blood the very most during CPR, where would you like blood to go? Absolutely, the heart, far and away. So you died, your heart's not beating. You'd like to get more blood back to your heart so that it will continue beating on its own again. So you want to have those pacemaker cells be getting blood so that your heart can continue beating. So the goal of giving this is to increase vasoconstriction and hopefully get more venous return and get more blood back to your heart, and obviously other places like, your brain and your kidneys and stuff that you care about, but later on. So epinephrine is our main sympathomimetic. It is a catecholamine, and low doses of epinephrine are recommended to start. Higher doses of epinephrine increase oxygen consumption by the heart, and can lead to worsened myocardial necrosis or death of cardiac tissue. And we give that every other dose of the BLS cycle, or every 4 minutes. Vasopressin is an interesting drug. So it is a vasopressor drug that works on a different type of receptor called a V1 receptor, that has a completely different mechanism of action, but ultimately a very similar action on the vessels where we get vasoconstriction. And it does not have any effects on the heart itself. The reason that this drug may be better in some circumstances than epinephrine is that aside from working from a different mechanism, it works really well even in an acidic environment. And so patients that are dead and have a very low blood pH, epinephrine may be less effective. And vasopressin is equally as effective in an acidic environment. The detriment of this drug is that it is quite expensive. It used to be more expensive than it is now. It used to be like $1,000 a vial. Now it's like $300 a vial or something. So it's not quite as bad as it was before, but still quite expensive. And sort of the hard part about it is that there's no definitive benefit compared to epinephrine. So we haven't seen any studies that say vasopressin's definitely better. So there are some specific circumstances where someone may choose to give this drug, but I would say in most cases that person should be a doctor and not a technician, just because the cost of CPR can go up by like thousands of dollars if you're giving a lot of vasopressin, and that's not a fun conversation to have with the client. The dosing would be the same. So some people choose to dose this instead of epinephrine, and some people choose to dose this alternating with epinephrine. So that would mean they would give epinephrine, 4 minutes later they would give vasopressin, 4 minutes later they would give epinephrine again, and there's no real evidence to suggest which plan is better. So our next type of drug is a parasympatholytic, so a drug trying to inhibit the parasympathetic nervous system. And the parasympathetic nervous system normally slows conduction of the heart, dilates blood vessels, and constricts the bronchi. So we want to do the opposite of all of that. So atropine would be our prototypic drug for that in a cardiac arrest, and it theoretically supports the sympathetic nervous system by decreasing parasympathetic tone, and that is usually given at the same frequency as epinephrine, so every 4 minutes. And I've had questions before about why not giving glyco rather than atropine. Atropine tends to work faster than glyco and have a shorter duration of action. And so in general, in an emergency setting, we want to try to use atropine rather than glyco. If you were in a situation where you had nothing else, sure, you can give some glyco. But in a hospital setting like this, where we have atropine in every room, we should probably just be giving atropine. One thing to know that is important is that all of the dosing on the Recover guideline dose charts that are listed around the hospital or that you would find online are for epinephrine 0.54 milligrams per mil. There, in the past couple years, has sometimes been a shortage, a manufacturing shortage, where this little bottle of atropine here with this red label has been produced, and it is 0.4 mg per mil. So it's important to know that if you're using 0.4 mg per mil here or anywhere else, that you're going to have to recalculate your total dose. And in general, we should be using the 0.54 mg per mil when we can, because that's what all of the drug charts are based on, and it makes it easier to not have to do math in an emergency setting. So IV fluids, which we discussed a little bit, so they're helpful in patients that have arrested probably due to hypovolemia, and they're probably harmful in patients that have an adequate blood volume. And more specifically, if your patient has arrested due to hypovolemia and the fluid that they lost was blood, if we have the ability to give them blood back instead of giving them Normasol or LRS, it is usually better to replace their lost blood with new blood. And so again, that's usually a conversation that a doctor is going to have, because it can cost like $5,000 of blood products alone to do 10 minutes of CPR. And so we want to make sure that people are on board for that. So our next step for advanced life support, so defibrillation, breaking that word down, is usually only used for patients that are fibrillating, so when they're in ventricular fibrillation, or pulseless VTAC, which looks very similar. Probably the most important thing to know about this, does anybody know what the goal of defibrillation is, like what you should be looking for after? So most people would say normal sinus rhythm. So the goal of defibrillation is to get back to asystole. So you want to just stop fibrillating and then have a pacemaker cell take over and eventually get back to normal sinus. And the old ways of defibrillating, what they would do in human medicine was 3 stacked shocks. So they would shock, see if you had gone into asystole, and if you hadn't, they would crank up and shock again and repeat that, so 3 times total. The newer ways, so what we know, just like cumulative doses of epinephrine, the more you shock a heart, the worse they tend to do in the long term, because we can see myocardial necrosis from defibrillation. And so the newer way of doing it is a single defibrillation followed immediately by 2 minutes of chest compressions, and then reassessing to do a pulse check and see what our rhythm looks like. And probably the single most important thing to know for defibrillation is to make sure that you are not touching the patient or touching the table that the patient is on. Absolutely making sure that everyone is clear and yelling clear so that we know we're not going to shock ourselves. When I was a vet student, one of the critical care residents was doing CPR on a patient in the ER, and we all have like badges that are on the like retractable things now, but she wore a lanyard, which was very common when I was a student, and she bent over to defibrillate, and her lanyard was touching the patient, and she truly shocked herself into the wall, like put a hole in the wall. So it's not really a joke how badly it can hurt you. That's probably the best case scenario of that, because she didn't have any arrhythmias or have to go to the hospital. But not a great idea to be touching anything. So biphasic defibrillation, external, we're going to use 2 to 4 joules per kg. Internal, we're going to use 1/10 of that, 0.2 to 0.4 joules per kg. Internal defibrillation is most typically only done in patients that are already undergoing thoracic surgery in the vast majority of cases. So I would say that this would be a fairly rare occurrence here. And then in terms of dosing, so we already said we're going to give a single shock, and then we're going to do 2 minutes of chest compressions and then assess our rhythm. And then in terms of dosing, we want to increase by 50% with each defibrillation attempt up to a maximum of 10 joules per kg. Some doctors would say that there is no maximum, because if you've already shocked them at 10 joules per kg and they're still dead, you're not going to make anything worse, which is probably super reasonable. So hopefully that's not something we're doing terribly frequently, but it's something you shouldn't be afraid to do if it's needed. If we're ever in a situation, again, hopefully not in this hospital, where we don't have a defibrillator or the defibrillator isn't working, a precordial thump is essentially a really strong single pound on the chest over the heart, and the same goal, to try to reset all of the cells so that the pacemaker cells can take back over and produce a normal sinus rhythm. Probably in place of that here, we would switch to antiarrhythmics, and the best antiarrhythmic drug in this instance, so for VFib or pulseless VTAC, would be amiodarone. And amiodarone, the old formulations were created with like benzyl alcohol, and it could result in things like an anaphylactic reaction and death. So it was sort of 50-50 if you make things better or make things worse. There is a new formulation of amiodarone called Nexterone that comes pre-mixed in a bag, which we have in stock on the shelf and in the crash cart. And so amiodarone would be the next goal if defibrillation isn't working, or for some reason we don't have defibrillation as an option. And I think lidocaine should be sort of under amiodarone, and probably precordial thump very, very last. So reserve that for if you're doing CPR on the street. So open chest CPR, can anybody tell me 3 indications for open chest CPR?
You're already in the chest.
You're already in the chest? Absolutely. What about if you're in the abdomen?
Yes, you just open the back and
Yeah. So if we're already in the abdomen, usually cutting through the diaphragm and doing open chest CPR is going to be good. If we're already in the chest, absolutely. Any other indications for open chest CPR?
if you have thoracic wounds in the chest.
Say that again?
If you have thoracic wounds in the chest already?
Potentially. So the consequence of having thoracic wounds would be something like pleural effusion or pneumothorax. And so if we think about a Labrador, and we're using a thoracic pump theory where we're trying to push on the chest and augment the intrathoracic pressures, if we have a large volume of fluid in the chest or air in the chest, we're going to be unable to adequately augment the intrathoracic pressures. And the last thing would be pericardial effusion, where even if you're pushing really well on the heart, you're probably not going to be able to push on the ventricles very well if there's a ton of pericardial effusion already squeezing down on things. So if we have pericardial effusion or a large volume pneumothorax or pleural effusion, those would be other indications for open chest CPR. And open chest CPR is not quite as complicated as a lot of people would imagine. So it can be done with like a scissors alone. And shouldn't really take very long. It is not the time to worry about sterile technique. If there are parasterile gloves around, fantastic. If there aren't, just keep going if there is a strong indication and owners are on board. And really the sort of big thing to know about open chest CPR is the quality of compressions is always better than when we're doing closed chest CPR. Every patient that has open chest CPR will need to go immediately into surgery to clean out the chest and to close everything up. So if we do get a patient back and we've done open chest CPR and owners are on board, it's a fairly rare circumstance, but I think knowing that we need to have an OR sort of immediately ready for that patient, so having sort of a hospital-wide knowledge. And when we talk about sterile technique, I think shave if you can, if it takes 10 seconds or less to shave. If you have a short-haired dog and there's not really time to shave, that's fine. If you have a German Shepherd, you're probably going to need to shave to even like cut anything. And then we treat these patients by copiously lavaging the chest after CPR and then by giving them a boatload of antibiotics, which is not a great plan in general. The other thing to know is that when we're squeezing the heart, there are a couple different ways to do it. Probably the single most common way to do open chest CPR is to do single-handed compressions, where we're sort of wrapping around, starting down at the apex. So the apex is the very bottom in all these pictures. So we're trying to squeeze the ventricles. So remember that we're not trying to squeeze the atria or occlude blood flow out of the pulmonary artery or the aorta. So you want to stay down at the apex, the pointy part, not the wide part of the heart. So we're going to say that we've gotten our patient back and talk about post-arrest care. So post-arrest care, if your patient is spontaneously breathing, what would be a fairly ideal end title for that patient? Yeah, 35 to 45 in general. There are some variations between dogs and cats. So the Recover guidelines specifically state 32 to 43 for a dog and 26 to 36 for a cat. I think that we don't need to be like terribly specific. If you're somewhere in the 35 to 45 range, you're doing okay. If you're sitting down in the low 20s, we might want to make some adjustments. If you're sitting 50, 60, 70, we certainly are going to want to make some adjustments. And so at our facility, we do not have an ICU ventilator for long-term ventilation. But if you are somewhere that does have that option and you have a patient who is apneic following return of spontaneous circulation, we would place them on a ventilator. And we would want to, at this point, try to titrate their supplemental oxygen, which can be done on an ICU ventilator. And in general, we want to try to keep their inhaled oxygen at 60% or lower. And the reason for that is trying to minimize oxygen-free radicals. So the more oxygen you have, the more oxygen-free radicals you can make, and the more things like ischemia, reperfusion, injury, and subsequent organ damage you can have. And so if you look at that top long pink bar, what you're looking for is a patient that you would consider normoxemic. Normoxemic would mean a pulse ox 94 to 98. Hyperoxemic would mean a pulse ox over 98. So if your pulse ox is reading 100 and your patient's getting flow by because they're breathing on their own, you might even just see how they're breathing without flow by. And if they're breathing great and have a pulse ox of 98 on room air, we might leave them on room air. And then what we would say hypoxemic, a pulse ox under 94. And then the other values listed there are PaO2 that you would be getting from an arterial blood gas. So what you're shooting for on an arterial blood gas would be a PaO2 of 80 to 100. So that's optimizing your respiratory care. And the next step would be hemodynamic optimization. And really, does anybody know what your ideal blood pressure would be for a post-ROSC patient? Anyone else? Higher, lower than 80? Or do we all agree? So an ideal blood pressure, systolic blood pressure, would be somewhere between 100 and 120. So what we're targeting is a pretty normal blood pressure. And if we're looking at a mean, so if we have an oscillometric and we can get a mean, we'd be looking for a mean probably somewhere in the 80 to 100 range. If we are hypertensive, we may decrease the dose of pressors that we're receiving. So if somebody had started norepinephrine, for example, we're going to want to titrate that down. We might consider treating pain if we've just broken this patient's ribs doing CPR. Or if we feel like we've already treated pain, they're off pressors, they are still hypertensive, we may treat them with antihypertensive medications. Probably the more common scenario, rather than hypertension, is hypotension. This is an older guideline from the Recover guidelines, and it is talking about hypovolemia and checking a CVP, or a central venous pressure. We should never do that, so don't worry about that. If we have a low blood pressure, we should assess volume status and consider either fluids or vasopressors, or potentially the addition of an inotrope to increase contractility. And then the last segment there is looking at an SCVO2, which is a central venous oxygen saturation, and looking at a lactate, and considering potential transfusion if we have something like a PCV under 25 to make sure we're going to be able to have adequate oxygen delivery. This is sort of getting into minutia of like critical care post-arrest things. But probably one thing all of the technicians can do, so a very technician-focused and important thing would be that bottom box in neuroprotection. So what we used to do was consider something called therapeutic hypothermia, mild therapeutic hypothermia. Now what we do is try to allow passive rewarming. So if a patient is 95 degrees, we might not put them on a bear hugger and a water blanket if they're post-arrest, because we've found that there's evidence of neuroprotection if we let patients be a little bit cold. And so rather than trying to actively cool patients, what we might do is just say we're not going to do a lot of the warming that we would do for a routine like post-op TPLO or something else. And we might consider something like mannitol or hypertonic saline. And then the very last thing there is seizure prophylaxis. So you'll see some doctors give drugs like Keppra, and Keppra can be given as a prophylaxis for seizures, or it can be given as a neuroprotective drug. There's a study in rats that suggests that it might be a neuroprotective. So you might see some doctors give that. And then the last thing that you might see is to try to decrease intracranial pressure, that all of these patients will be put on a slant board and have their head elevated 30 degrees after they've achieved ROSC, and that's to try to make sure that they get venous drainage, so the blood in their head makes it back down to their body, so they can hopefully have a fairly normal intracranial pressure. And so some of the nursing considerations would be elevating the head as soon as we get ROSC, checking a temperature, seeing what our temperature is, not overly warming, which we're trained to do, and then asking the doctor about mannitol or hypertonic saline, which all of my post-arrest patients get hypertonic saline, and considering those things. So that's some post-arrest care. All right, quiz. Anyone?
C.
Absolutely. Who was that? No more pens for you. Do you want to give a pen to a friend? Does anybody want this dinosaur pen? It's gorgeous. You want this little dinosaur? There you go. All right, great. So what's the correct order of life support for a cardiac arrest patient? Say it again? Absolutely. The correct location for hand placement for chest compressions? Absolutely, nailed it. Ventilation rate? Yep. And what did you measure during CPR? So I would argue that a pulse ox doesn't tell you much of anything during CPR. So the A and D are both mostly right, but probably if you're going to do a third thing, I would say the big two are end tidal and EKG. So like no one's wrong. But Peripheral pulses are probably, if you have like an extra person to stand there, peripheral pulses are probably going to be more sensitive than looking at a pulse ox, which sometimes reads like 100 on a towel and 50 on a healthy patient. So if you're going to spend your time doing a third thing, I would say pulses over EKG, but not looking at pulses to determine for a long time whether or not you need to start CPR. So if you already started CPR and you're assessing pulses, that's fine, but don't spend 30 seconds trying to feel a pulse before you start CPR. All right, atipamezole. Great. Naloxone? Hydromorphone? Anything else? Fentanyl? Yep. And flumazenil? Great. All right. True or false? Love that. All right. So this is just a little factoid thing. So we sort of talked about a lot of this. So CPR is more likely to be successful in anesthetized patients. That is probably due to CPR being a consequence of anesthetic complications and being able to reverse many of our anesthetic drugs, and also those patients having IV access, already being intubated, being able to start chest compressions quickly. So we're way ahead of the game on most anesthetized patients as compared to especially like out of hospital cardiac arrests. Animals that receive reversal drugs during CPR are more likely to achieve ROSC, and that's true because, again, a component of their cardiac arrest might have been due to those drugs. That's not saying that, like, you killed the dog with hydromorphone or methadone, but if a really sick dog that was like bordering on arresting got some dexmedetomidine and some hydromorphone, maybe they end up dying, but you can get them back quicker if you reverse them. And sort of common sense, but in-hospital arrests are more likely to achieve ROSC than out-of-hospital cardiac arrest, and that's true for veterinary and human patients. So most dogs who achieve ROSC do so fairly quickly, so under 13 minutes. So you might hear some doctors, especially if we have limited staff or multiple other sick patients, or a patient comes in with an out-of-hospital cardiac arrest that looks very dead, say that we're going to sort of max out at 15 minutes of CPR and that's all we're going to give it. And sometimes that's due to limited resources, but truthfully, looking at a lot of the data, many of the patients who are going to come back do come back within that first 15 minutes or under 13 minutes. There certainly are some outlier cases where you'll do CPR over an hour and get patients back. I think that a lot of those patients are not what we would describe as neurologically intact. So then the question starts to become like, even if I can get your dog or cat back, is it your dog or cat anymore? And then another little interesting tidbit, sort of going back to our previous quiz question, if you can feel pulses during chest compressions, ROSC is more likely, and that's generally an indicator of the fact that you're probably doing really good compressions if you can feel pulses generated from those compressions. And just to really end this on a sad note, survival to discharge after CPA is 5%-ish, 3 to 5% depending on the study you read. 3 to 6% listed here. The chance of any ROSC after CPA, so it's a little bit different, between 13 and 60% in dogs and 15 and 57% in cats. The reason that this is so wide is they included patients under anesthesia, in hospital arrest, and out of hospital cardiac arrest, so it can be really quite variable. But probably the most important thing for us to know is the really staggering difference between achieving ROSC and discharge from the hospital. And so that is where it gets into sort of the finesse of things, like do we do high-dose CPR, do we do drugs like sodium bicarb, have we done appropriate post-arrest care, making sure we're not hyperoxemic, making sure we're treating intracranial pressure, all of those little things, because that's probably where some component of the difference between patients that achieve ROSC and patients that are discharged lies. Certainly not all of it. Some of those dogs and cats and people are just going to die anyway. But there may be some benefit sort of in that little middle ground. So this is just more fun facts, that apparently the people on ER are doing great, and Rescue 911. So this is some older data, but still relatively true. So some large studies for out-of-hospital cardiac arrest patients. In humans, survival to discharge was 7.6%, higher than in veterinary medicine, probably in large part because they have like EMS services. And in-hospital patients, survival to discharge was 17.5, so they're clearly doing better than us. Oh no, we're not doing drills. I think that's it. Who has questions?
Can you explain the hypothermic comment you said earlier that now we don't want to run them because
Yeah, so we used to do a thing called, in human medicine, they were recommending we did it somewhat in veterinary medicine, called mild therapeutic hypothermia. And the goal was to try to have a lower incidence of organ damage. So if your metabolic rate is lower, your brain is happier as well. So if we keep patients cooler, somewhere between like 89 and 96, they may have a lower incidence of things like recurrent arrest or brain injury following arrest. So there are some protocols for specific neurologic diseases where therapeutic hypothermia can be really beneficial. So there was a period of time during medicine where we thought, okay, every patient that achieves ROSC for cardiac arrest, regardless of the cause of their arrest, we're going to treat like we treated these neuro patients that did well with therapeutic hypothermia. And what we found was, just like with achieving like glycemic control, like maintaining a normal blood sugar, it's really hard to do. So like, how often have we seen a diabetic or a DKA patient here that I can keep the blood sugar between 80 and 120 all day long? Like never. No one can do that. And so what they found was patients that you tried to keep like a little cold but not too cold, it's really hard to do. And some patients would be detrimentally cold and end up doing worse from how cold they were. And so rather than doing that, the guidelines now say we're going to limit the active rewarming we do, so they maybe get some benefit from their hypothermia. So if they're 94 or 95, maybe we put a blanket on them, but there's no bear hugger, there's no water blanket, and we're going to let them slowly recover because that can be neuroprotective. But we're not going to try to like intervene so much that we target them to like sit at 92 degrees, because just like the heat stroke patients that come in at 107 and you're like, we're going to stop cooling them at 103, and you stop cooling them at 103 and 10 minutes later they're 96, it's really hard to target. And so the sort of first do no harm idea of, we want to make sure these patients are doing well, rather than trying to intervene to like keep them cold, we just let them warm up a little bit slower, because that might have some neuroprotective benefits. Anyone else? All right, you're all free. Thank you for coming. Everyone take a pen.
Thank you.
Oh, Alex,
Hey,
man.
Dr. Barton,
Yes, ma'am.
I do have a question, because I thought it was helpful, but I don't know how you feel about it. But that Recover app on the phone is very nice for telling you when the 2 minutes are up, for telling you when to give the breath, because it has a breath sound, and it tells you to check for pulse or check for EKG.
I've never used that.
It's really nice, because it has it, I have it on my phone, but you hit a button and it's the TikTok, you don't even have to know your song. It tells you like the rate of compression, and
Nice.
it's a little breath that goes. So you know that that's time to give your breath. It's really nice. And it
Great.
keeps total track of what you did and what you gave and when you gave it, so that you know how far you're into it.
Yeah. Well,
It's
everyone
really,
download it.
Really nice app, and Khalil has used it. It's
great.
Use it for our
Yeah,
last CPR, and
we did it in our last CPR.
Awesome.
So
I love that.
and you'll be, you guys will be
It talks to
not
you.
surprised to know that I accidentally hit it at the drugstore the other day. I couldn't figure out how to turn it off. But listen, don't
Yeah,
put
it
it
is.
on, and you
It's
can
nice.
just hit it. That's
Especially
it.
the
Oh,
smell
yeah.
over there.
There,
See
okay.
how it
Yeah.
goes?
It's really nice.
That's it. That's all. When you start your
Like